Hello, and welcome to our third lecture. This will be the final lecture on pharmacokinetics. Here we're going to be talking about termination of drug action. And in particular, one of the things we'll be focusing on is what is called metabolic half-time, or drug clearance time. As usual, please remember these video lectures are for educational purposes only. Please consult your physician or pharmacist for any questions about medications or drugs. So we've been talking about how drugs are handled by the body, and now we're going to get into how drugs leave the body. We'll start first by talking about routes of elimination. Most drugs are primarily eliminated by the kidneys and are excreted as urine. Lipid-soluble drugs tend to be reabsorbed and have to be transformed into metabolites before they're excreted. The lungs are also another method by which drugs are eliminated. Typically only volatile drugs like alcohol or gaseous agents, so things like gas anesthesia. So alcohol and inhaled anesthetics are two of those methods. Reason breathalyzer tests work the way they do is your lungs are excreting alcohol as blood with alcohol in them travels through them. And so your breath contains alcohol. It's not that they can smell the alcohol that you've been drinking, but it's actually alcohol that's being expired by your lungs. So it's not that it's gone through your mouth, although certainly that can do it as well, but because it's being excreted by your by your lungs. Your liver will excrete bile back into the intestines, and then oftentimes drugs are reabsorbed when they go back into the intestines. And then finally, drugs can be eliminated via sweat through the skin. Certainly, I have had more than one student in my class who's sweating out last night's booze, and it's fairly apparent. And so we've all sort of experienced sort of the smell of that kind of experience. And some drugs can also cause a pretty tough smell. So some drugs, for example, might be come out in sweat smelling like garlic, for example. So drugs are biotransformed or metabolized primarily by enzymes in the liver. So this metabolism is defined as chemical changes that reduce the effect of drugs and increase their excretion, and oftentimes turns them into something that is easier to excrete. So our kidneys, of course, filter waste from our blood and collect it in the bladder, and so those waste products of drugs are part of the other kinds of waste products we excrete. As I said a minute ago, lipid-soluble drugs are much harder for the kidneys to hold onto after collection. And those molecules have a tendency to cross back into circulation before they're excreted. And so oftentimes those have to be transformed further before they are excreted. Tetrahydrocannabinol, which is the primary ingredient in cannabis or marijuana, is very lipid-soluble. And oftentimes, actually, it gets absorbed into your body fat. And so it's very difficult for your kidneys to excrete. And in fact, that drug is most often excreted as feces. So the liver is what protects our body from toxic substances, contains enzyme systems that can detoxify harmful substances. Of course, the drug that causes the most damage to the liver is primarily alcohol. Other drugs are particularly hepatotoxic, drugs such as acetaminophen, or for those of you in the UK, paracetamol, which is the primary active ingredient in Tylenol, is particularly harmful for the liver. The liver changes some drugs from highly lipid-soluble to less lipid-soluble, and this allows them to be excreted by the kidneys. They're also more likely to be ionized. And finally, may produce another lipid-soluble molecule, or what we call an active metabolite. So many drugs have active or inactive metabolites, and so oftentimes that active metabolite is actually the target we're after. So with, for example, hydrocodone, we are actually waiting for that to be actively metabolized into hydromorphone. And that active metabolite, hydromorphone, is actually what causes pain relief. Hydrocodone causes no pain relief, but it's actually converted by the liver into hydromorphone. And so that active metabolite often is an important consideration. So the liver handles drugs by transforming and by enzyme transformation. Enzymes are a really important part of understanding both how the body handles drugs and how the brain handles neurotransmitters. And so enzymes are an important part of this entire process. Most of these aren't particularly specific. In fact, we usually talk about a class of enzymes attacking a number of things. These are microsomal enzymes, and their main category is the cytochrome P450 enzymes. We'll talk about different variants of cytochrome P450. A number of important ones we've already talked about are cytochrome P3A4 and 2D6. These are physically located in hepatocytes, which are the liver cells. So when we talk about hepatotoxicity, we're usually talking about damage to those hepatocytes. And in particular, as I said, chronic alcohol abuse tends to be particularly hard on the liver. So these are the sort of approximate proportion of drugs metabolized by the cytochrome P enzymes. So as I said, 3A4 and 3A5 are particularly important. 2D6 is another important one we'll talk quite a bit about. So these cytochrome P enzymes are really an important part of considering how the body handles drugs. And anything that has an effect on these enzymes, for example, drinking grapefruit juice or taking another drug like a selective serotonin reuptake inhibitor, or even your genetics, can affect drug metabolism. So two major phases of drug metabolism, phase 1 and phase 2. Phase 1 is usually the cytochrome P450 enzymes. These are, of course, most concentrated in the liver. And as you just saw, there are about 12 cytochrome P families that have effects on various types of drugs and can be affected by various drugs as well. Cytochrome P1, 2, and 3 are the most common for drug metabolism. 2D6 and 3A, especially 3A4, metabolize over 50% of drugs. So these are the two we're going to talk about quite a bit. And in fact, there are now a number of medications that specifically inhibit some of these enzymes in order to allow another drug to have a longer metabolic half-life. So for example, one of the HIV antiretroviral drugs that's a combination, there's Genvoya and Stribild. And they're both fairly similar, but they contain a cytochrome P3A inhibitor to allow one of the other components of that particular four-drug combination to have a longer metabolic half-life. And so that drug only has to be taken once a day rather than twice a day. So some factors that influence cytochrome P450 enzyme activity include disease, particularly of the liver, and what species you are. We're, of course, talking primarily about humans, but keep in mind when we're talking about how drugs are handled, not every species handles drugs the same way. So this is the reason why, for example, you can't give your dog ibuprofen, whereas you can give your dog aspirin. Another good example is diphenhydramine, which is Benadryl. Dogs actually require a much larger dose to get an effect from diphenhydramine than do humans. So a 40-pound dog, a 50 milligram dose of diphenhydramine is about right, whereas a 200-pound person, that 50 milligrams of diphenhydramine is probably going to put you to sleep. You'll probably get a good night's sleep out of it. Certainly age, younger and older, there are huge differences compared to a regular sort of healthy adult. Older adults tend to have slower metabolic clearance times, as do younger adults or kids. Always keep in mind, kids are not just smaller people. They have very different bodies. And so what you might try to just lower the dose for a child is a particularly bad idea. So always check with your pediatrician in terms of drugs in your children. Genetics is another important part of this. We're getting a better understanding of this. We're going to talk a little bit about differences in cytochrome P2D6 and how we metabolize painkillers. There are 4 different genetic variants of that particular enzyme. In fact, you can get a report on that from 23andMe. It's part of their report now, is that that sort of metabolism. We'll talk a little bit more about this throughout the semester. This is an area we call pharmacokinetics. And understanding how pharmacokinetics work is a really important part of understanding modern pharmacology. And so, for example, people who have red hair have a very different drug metabolism than do the rest of us. Because of their genetic structure, they metabolize drugs more quickly. In fact, they're very difficult to get anesthetized and very difficult to get numb at the dentist. So we'll talk more about that later on. The environment's another important part of that. Things like what you've eaten, oxygen levels. So, for example, you might metabolize drugs differently at high versus low elevation. I'm currently located in Colorado, which is where I grew up. High altitude tends to result in greater intoxication for people who aren't used to it. So we always tell people who come to Colorado take it easy on the booze for the first couple of days. Conversely, when we travel down to sea level, we can generally process liquor very differently, and that has to do with the amount of oxygen in the environment. One of the things that often happens is what we call enzyme induction. So past experience with drugs can affect enzyme systems. And in fact, what happens is it's essentially an immune system response. Your body gets more efficient at metabolizing a drug, and this is one of the reasons why drug tolerance occurs. So much like when you get vaccinated, your body can now attack the measles virus, for example, and you won't get sick. Your metabolic enzymes also get experience with drugs and get much more efficient at delivering them. And in fact, one of the things that will happen is environmental cues will tell your system to start pumping out more enzymes that it needs. So for example, drugs of abuse are where we look at this a lot. So if you present somebody with cues related to cocaine use, they will start producing enzymes, so that is if they've used cocaine, the body will start producing enzymes to metabolize that cocaine out. So those level of enzymes increased by previous exposures to these specific drugs. And again, we call this enzyme induction. And it just simply is getting your body ready to handle that influx of a substance it wants to get rid of. One of the biggest problems with enzyme induction is it's not forever. And so one of the things that happens is when people go into rehab, the goal, of course, is to stop using a drug. But oftentimes people relapse. But when they relapse, their body's not ready. That is, they're no longer producing these enzymes, and their body's not ready to produce these enzymes in the level they did before. So the same amount of drug can oftentimes lead to overdose because they no longer have that enzyme induction. And so it's a really important part of understanding the sort of rehabilitation process. Something to keep in mind. Some example of the consequences of taking things like supplements. One of the things you have to be very careful of, we oftentimes think of supplements as, oh, they're just harmless. It's just like taking a vitamin. Even vitamins can affect different drugs. But St. John's wort, for example, people often take because they believe it helps with depression. So it stimulates the receptor in the liver to induce cytochrome P3A. So it increases the metabolism of cytochrome P3A. So that breaks down a lot of drugs. So asthma drugs, warfarin, which is an anti-clotting drug, birth control pills, cyclosporin, which is an important immunosuppressant. So sometimes it's important to really consider very carefully and also tell your doctor any supplements you might be taking. I think it's a really important thing to keep in mind about this kind of enzyme induction problem, because this is a more complex, nuanced way of thinking about it. There are also apps you can download and enter drugs and supplements that you're taking, and they'll tell you about whether or not you should be taking drugs at certain drugs together. So it's an important thing to keep in mind. Other things that can happen is enzyme inhibition, which is of course the opposite of enzyme induction. So some drugs and foods inhibit cytochrome P enzymes and increase their own levels, as well as levels of any other drug metabolized by that enzyme, and these can produce toxicities. So again, important to understand drug interactions. So when you're taking a drug that has an effect on these enzymes, you have to understand how it might affect other drugs. So for example, antipsychotic medication is sometimes inhibited by selective serotonin reuptake inhibitors. Another thing that often happens is with some SSRIs, we also get inhibition of cytochrome P2D6, and as a result, people who are on those SSRIs don't get any pain relief from drugs like hydrocodone. So it's really important to keep that in mind. We talked in the previous lecture about grapefruit juice, and it actually can cause several-fold increases in levels of particular drugs, and this can result in augmented therapeutic benefits or toxic effects. So the magnitude and mechanism of this interaction appear to be the result of significant inhibition of gut wall cytochrome P450, particularly 3A4, isoenzymes, and P-glycoprotein. And this fruit-drug interaction is really important. There's about 21% of households in the United States consume grapefruit or grapefruit juice. It's very good for you. It's certainly something I would encourage. But you also have to keep in mind that certain drugs might be affected by intaking significant amounts of grapefruit. And so it's an important mechanism to understand. So for example, Xanax, which is a fairly powerful benzodiazepine sedative, is metabolized by cytochrome P3A4. And so if you have had grapefruit juice, you will get a much more significant sedation effect from that Xanax than you would otherwise. And so you might find yourself in a dangerous situation, being unable to drive. So be very careful with those kinds of drug-food interactions. So basic idea here is we have a drug, and this gut, well, I did not create this very hard to read graphic, but gut wall cytochrome P3A4, that grapefruit juice inhibits that first pass metabolism, and as a result, we get much greater circulation in the blood. Another thing we've talked just briefly about is cytochrome P2D6. We'll talk more about this later on, but there are about 20 to 30 million subjects who have no cytochrome P2D6, so they metabolize drugs very slowly. They get no response from certain prodrugs like codeine or hydrocodone. There are about 50 to 20 million people who are what we call ultra-metabolizers or rapid metabolizers who have duplicate copies of the cytochrome P2D6 gene. These people rapidly metabolize drugs. Oftentimes we get no drug response at ordinary dosage, and importantly, for drugs like codeine and hydrocodone, they will oftentimes make people sick, or they can even cause overdose because they are creating so much hydromorphone from that codeine. There have been a number of instances in which nursing mothers recovering from hysterectomies have been given hydrocodone, and because they're ultra-metabolizers, they have overdosed their infants in their breast milk. So this is an important consideration. This particular gene is available as part of the 23andMe health package. I'm not paid by 23andMe, I'm simply explaining that it is available. And so if it's something that you're interested in or concerned about, that is one way to find out that information. So there are a number of different variations in the cytochrome P genetics. And so this can really change the metabolism of drugs. And this is going to be a really important consideration moving forward. Pharmacokinetics, there are a number of important components for us to consider. We'll talk about, when we talk about nicotine, there appears to be a specific genotype of people that are far more addicted to nicotine than others, and these are the same people who don't respond to varenicline or Chantix because they lack the receptor for that particular drug. And so genetic testing is probably in the future for a lot of different drug types. In particular, the other area we're looking at is antidepressants. So this is essentially the ways to think about it. If we have a normal metabolizer, genes produce a typical amount of enzyme. Your antidepressant will help your depression, won't cause very many side effects. If you're a slow metabolizer, you're going to end up with too much antidepressant in your body, and that's going to result in intolerable side effects. And so you'll have to go to a lower dosage or just switch to a different antidepressant that's metabolized by a different enzyme. A fast metabolizer, they're going to get very little improvement in their depression because it's getting eliminated so quickly. So again, the solution is to try a different antidepressant or increasing the dosage. Again, all of this under consideration with your doctor or pharmacist. So finally, we get to some drugs that are not metabolized are actually excreted intact. So lithium, which is an important drug we'll talk about with treatment for bipolar disorder. Mushroom Amanita muscaria in large doses can be toxic and lethal. In small amounts, this is a hallucinogenic type of drug. It's a muscarinic drug. Hallucinogenic ingredients are not greatly metabolized from this particular type of drug and are passed in the urine. Siberian tribespeople discovered this, and they recycled the drug by drinking their own urine. They are not the only people who do that. People who use methamphetamine are also known to do that because methamphetamine is excreted intact in urine. So yeah, that's all I have to say about that. So excretion primarily, again, accomplished by the kidneys. Kidneys, their job is to keep us the right balance between water and salt in the body. Your brain and your kidneys work together to try to maintain the same amount of salinity and water in your body. And so if you don't have too much salt, you'll retain water. And so actually the solution is to drink more water, because then your body will recognize that you now have enough water for the amount of salt you have, and then you'll begin to excrete that water. They filter everything out of the blood and then sort of selectively reabsorb what is required, so some nutrients, for example. The pH of your urine can be manipulated to alter excretion of drugs, and in fact, this can be a side effect of certain drugs. So for example, painkillers often cause pretty severe constipation, and that constipation can actually change the pH of your blood, which can then very dramatically alter your cognitive status. My father had a liver transplant and then also had lung cancer, and this is one of the things that would happen because of the side effects of those particular drugs. But that sort of alteration of the pH can be useful for eliminating certain drugs in an overdose. So there's a lot of consideration there. Oftentimes, one of the things that's important in overdose is just simply hydration, getting the kidneys flushing as much out as we can. So that gets us to rates of elimination, and this is a really important part of understanding drugs and how they function. We call this half-life. This is the rate of excretion for most drugs, can be described in terms of a half-life. Alcohol does not have a half-life. Alcohol is eliminated in a linear fashion. It's about 1 drink per hour. That's an important consideration. We'll talk more about that when we get to alcohol. So the time taken for the body to eliminate half of a given blood level of a drug is its half-life, and this is dose independent. And we'll go through some examples here in a moment. But understanding this time eliminated to eliminate half of the dose of a drug is particularly important when we're trying to maintain a particular rate or amount of drug in the body. So this is a fairly straightforward half-life calculation. The first half-life, we've eliminated half of a drug, so half is left. We're going to eliminate half of that again in the next half-life, so now we've eliminated 75%. We're going to eliminate half of that again, so we have 12.5% left. Half of that, half of that, half of that. So it takes about 5.5 to 6 half-lives to completely eliminate a dose of a drug. This has important considerations, again, for understanding maintaining steady state. And in fact, the easiest way to figure out maintaining steady state is it's usually the same number of half-lives. And so if a drug has a 30-hour half-life, it's going to take 150 hours of taking that drug every day in order for you to reach steady state. So whatever 150 hours is, what about 7 days? Excuse me. So for most drugs, the amount of drug metabolized is proportional to the amount of drug present. So this is what we call a first order system. So I have an enzyme that can break down 50% of the amount of administered drug in 30 minutes. We give 100 units of the drug, so 50 are metabolized every 30 minutes. Or for the first 30 minutes, then 25, then 12.5. If 1,000 units are present, then 500 are going to be metabolized in that first 30 minutes, and then 250, etc. So the system gets sort of the same proportion of a drug in a given time period. So for our 1,000 unit drug, after 30 minutes, we'll have 500 units. After an hour, we'll have 250 units. After an hour and 30 minutes, we'll have 125 units, etc. So this is an important part of understanding drug elimination. So this is the plasma concentration time curve for a particular drug. And you can see this is a curvilinear elimination time. We're getting half the drug eliminated, in this case, every 4 hours. So the nature of this curve is going to depend on the elimination time or clearance time for a particular drug. So steady state is this point of balance at which the rate of a drug administration approximates the rate of excretion. And so this particular component is very important when you need to maintain the amount of drug in a particular person. And so, for example, oftentimes we want an antibiotic to be at a certain level. And so oftentimes what we might do is give a large dose at the beginning. We call that a loading dose, and we'll talk more about that here in a moment. So here we have a basic idea of steady state. So if we give some administration of the drug here. That dose is going to be eliminated by this curve. But now we're going to give another dose, and so we're going to boost up to here, and then we're going to do another dose, and then eventually we'll get to this sort of fluctuation within the range that we're into. So that steady state's attained after approximately 5 to 6 lives. It's really independent of what the dose is because it's proportional. So it's going to be proportional to the dosage interval and the half-life. So the times with which we will be giving a drug are often based on this half-life consideration, which is why it's very important to closely follow directions for drugs. So we want to get the right amount of drug maintained in the blood. That's what we call that therapeutic window. If it's too high, we're not going to get any more therapeutic effect, but certainly this is when we're more likely to get undesirable side effects. Too low, we're not going to have any beneficial effect. In particular with antibiotics, this is where oftentimes we get resistance to antibiotics because the level is too low. So we want to give drugs in such a way that the blood concentration stays between a level that is too high and too low. And again, we call this the therapeutic window. Most of you have probably at some point in your life taken a Z-Pack. The dosage on that Z-Pack is meant to get you into the therapeutic window quickly. So usually it's you take more the first day and then 1 every day after that. I can't really remember. It's like 2 the first day and then 1 every day after that. The point of that is to get your levels to the point where we're up in that therapeutic window, and then we maintain you by giving you 1 every day. Important things to consider, and this is going to be our last bit for this particular lecture, is drug tolerance. This is a state of progressively decreasing responsiveness to the same dose of a drug. So we have a number of different mechanisms involved in the development of drug tolerance. Metabolic tolerance is one of the things we talked about with things like enzyme induction. Your body just simply gets more efficient at eliminating that particular drug. Cellular adaptive tolerance, and this is basically your, in our case, in drugs and human behavior, we're primarily talking about downregulation of neurons that just simply don't respond as strongly to the presence of that particular substance. And then finally, behavioral conditioning processes. Oftentimes we change our behavior related to that sort of drug tolerance. Finally, is the question of physical dependence, and this is an issue that's going to come up in a variety of instances. We call this an abstinence syndrome. So when people are withdrawing from a drug, they'll have physical symptoms. And this can be very variant depending on the drug. So for caffeine, most of us who are addicted to caffeine or dependent on caffeine will get a headache, will be tired and sluggish. For people who are addicted to nicotine, there is a wide variety of symptoms in the abstinence syndrome, difficulty concentrating, difficulty with memory, crankiness, etc. So we're going to talk about these issues in a variety of cases based on a variety of different drugs. Again, big important in understanding pharmacokinetics. It's crucial to understanding how drugs work. This is an important part of education about drugs because the specific drugs available will change with time. So being knowledgeable about those pharmacokinetics can provide you with the skills to interpret information about any drug. And this is really important for consumers, policymakers, people who are trying to understand how drugs are handled by the body is an important part of that. And so thinking about regulating drugs, regulating recreational drugs, understanding how they're cleared, things like drug testing, all of these things are important parts of understanding pharmacokinetics. And as always, some great resources for you if you have any more questions about these issues.